We have Claire Buckley, Finola Donoghue and Professor Austin Stack presenting on transforming chronic disease management through novel national surveillance programmes and disease registries. So I think Claire is going to lead off and she'll be joined by colleagues.
Thank you very much and hello everyone. Today I'm going to talk about the use of chronic disease data to transform chronic disease management in Ireland. Three of us are going to present on this topic this morning. I'm going to start off and I'm going to talk mainly about diabetes. My name is Claire and I work as a public health doctor in the HSE. Professor Austin Stack then is going to follow from Limerick and talk about kidney disease. And then Dr. Finola Donoghue from Dublin, who works in the National Health Intelligence Unit here in the HSE, is going to give us some possible solutions to the challenges that we face. So chronic disease. A chronic disease is one that lasts for a long time, usually over a year, and there are a number of different chronic diseases and a number of different causes. It's estimated that approximately 1.3 million people in Ireland live with one of the chronic diseases that are listed on the screen, and it's anticipated that nationally and internationally this is going to increase because our population is getting older, the way we engage with risky lifestyle behaviours, and our rising levels of obesity. And chronic disease impacts on multiple levels. It's tough on the person who has the disease and the people who are caring for them. It's also putting a huge pressure on our health service, as we know. And also, unfortunately, people are being diagnosed with chronic disease younger and younger in life. So this is affecting their working years, and this is impacting on our economy. So looking to diabetes. In essence, diabetes is where there's excess sugar circulating in the bloodstream. And the management of diabetes is multifactorial, but it involves improving your diet, increasing your physical activity, taking medications, which can include oral medications or injections like insulin. And the ultimate aim of this is to achieve a life expectancy and a quality of life that are similar to that of the general population. But unfortunately, people with diabetes do develop complications. And these affect all organs in the body. People with diabetes have an increased risk of heart attacks and strokes. They can get problems with their eyesight and potentially go blind, problems with their kidneys, needing dialysis, and problems with their feet, which can develop ulcers and require amputations. And I started my own medical career as a GP, and this is a photograph that was taken of a patient that I went to see in a house call years ago now at this stage. And this man had diabetes, and unfortunately he ended up with, as you can see, bilateral amputations due to that diabetes. And this house call has stayed with me for a number of reasons. The first one was that the man and his wife really appreciated the fact that I called to their house to help them. And that really talks to what Sláinte Care is about, bringing care into the community, into the patients, and taking it out of the hospitals wherever possible. The second thing was, this is very sad. Like, this man and his wife had a very poor quality of life after a lifetime of risky lifestyle behaviours, and this is how it had ended up. And it really was sad, and I was thinking, how had the system failed him? How had we failed him? What could we do differently? And what kind of numbers did we have of people with diabetes who ended up getting amputations? And it's not available. We don't know that number. We don't even know how many people have diabetes. We can't count in Ireland at the moment. So we have a problem with diabetes data. So looking to other countries, how have they solved this? We've heard this morning about the great registers in Denmark. And I think when we're talking about national diabetes registries, it's very important that we know the words we're talking about and that we're all speaking the same language. So to me, a register is a database of people with a certain condition, so in this case, diabetes. And the registry is the organisation, the process all around it to enable the data to be used. In Europe, we have fantastic diabetes registries. These lead the way in the worldwide context, in Scotland, in Scandinavia, and in Denmark. But these national diabetes registries are expensive, and there's a lot of money spent setting them up and establishing them and maintaining them. But the reason that's done is because there is really good evidence that diabetes registries do improve outcomes in a number of ways. They improve clinical care, so healthcare providers promote the management of diabetes, prevent complications. It also enables trends to be estimated, so we can see what's happening in terms of amputations. Are trends going up? Are they going down? Are they the same? What is happening? And this information then is really useful to help us to inform our service planning and how to allocate our resources. And of course, today's conference is about research, so National Diabetes Registry's enabled research, so we're continuously learning and continuously improving our care. So based on the vision from the international countries and the fact that we have such a problem in Ireland with diabetes data, we brought together a very diverse group of stakeholders and we wrote a proposal which the Department of Health has kindly agreed to give us some funding to, so thank you for that. And the vision in this proposal is that we, over the next approximately 5 years, are going to develop a national diabetes registry. And this registry has 4 goals, which are to improve patient care, look at trends over time so we can see what's actually happening with our patients with diabetes, and therefore plan our health services better and do research. On the next screen, you can see the stakeholders that we've engaged with that have helped to write the proposal. And I'm not going to go through each one, except I do want to thank everybody for help and input, and also emphasise how important it is that everybody on the screen here is involved. We can't do this without all these partners. Everyone has a voice, everyone has a place to play if we are going to pull it off and get a national diabetes registry in Ireland. It's a very exciting time. There's great opportunities. The Science Foundation of Ireland has also funded 2 big research projects, one in diabetes and one in chronic disease, with similar goals. And we have partnered up with these research projects, and we're going to work together, pool resources to try and achieve our goal. But there are challenges, and there are legal challenges, technical challenges, and governance challenges. Traditionally, registries have been outside of the health system, so maybe it's time to rethink that. And Fionnuala in a minute is going to give us some options for how to overcome these issues. We also really want to avoid reinventing the wheel. We need to learn from what's happened before, where success has been. And Austin is going to tell us about his story with kidney disease in the Limerick area and how they have achieved what they have. So I'm now going to hand you over to Austin to hear about kidney disease. Thank you.
Good morning, everyone. Austin Stack is my name. I'm a kidney specialist at UL Hospitals. I'm also the chair of medicine at the School of Medicine in UL. And at least 50% of my time, I look after patients with kidney disease from early stage to late stage, right on to dialysis and kidney transplantation. So similar to Claire in terms of chronic disease, I'm going to focus on chronic kidney disease. And you might say, why? Because it's extremely common. It affects about 10% of the Irish population. 1 in 10 adults have chronic kidney disease. It's about 400,000 individuals. It's the 12th leading cause of death. About 14% of all hospitalisation in Ireland have chronic kidney disease or dialysis as a primary or secondary diagnosis. And over 500 new patients start dialysis every year. It's costly to patients in terms of morbidity, mortality and quality of life, and also costly to the health system in terms of financial impact. So the overarching goals of the National Kidney Disease Surveillance and Quality Assurance Programme are to really better understand chronic kidney disease in Ireland and in our health system. So our aim is to determine the frequency of kidney disease and the associated risk factors, to measure the quality of care delivered to patients across the primary and secondary healthcare system, to quantify the impact of interventions and ranges of interventions on major clinical outcomes like hospitalization, dialysis, mortality, and as well to inform and support strategic planning and resource allocation so that we can build a health system that can manage these patients now and into the future. So some of you might agree that our healthcare system is in silos, not chaos, in silos. And every day in the hospital system we deal with, manage hundreds and thousands of patients from the emergency department through the outpatient clinic and through inpatient wards, with a couple of hundred information systems. But unfortunately, the majority of these do not link or speak with each other. And similarly, in primary care and in community care, we've got hundreds of thousands of patients who are managed on a daily basis. And again, maybe better than the hospital, but there's very little integration or longitudinal management of these patients or profiling. And because we have a siloed system, it does mean that integration of healthcare data is virtually impossible. And so that we lack visibility on patient flow, it's difficult to conduct either local, regional, or national quality improvement programs. And at any time point, we can't do any real-time data analytics. So we don't know at a time point how many individuals have a disease or have the risk factors for disease or on a specific treatment. So substantial progress must be made. So to better understand chronic kidney disease, we embarked boldly on an ambition to integrate clinical data, large clinical data sets across the Irish healthcare system. And the premise is that if we could link these silos of information that are readily available at this time point, that we would have a better understanding of the burden of kidney disease, the impact, and the quality of care provided to patients. And so we went on a journey of interaction, engagement with a range of stakeholders, including the state agencies within the state, the Health Service Executive, the Central Statistics Office, the data owners for the hospitalization data in the state. We worked with academic partners to bring us the firepower to help us link and analyze that clinical information. And importantly and finally, we worked closely with the Data Protection Office in guiding us in developing the information governance to get their permission to link data, extract data, and to do it with the appropriate privacy and security concerns intact. So through this engagement and through this process, we developed a technical an information governance solution and an ethical framework to link clinical information within the state. And following completion of data agreements, privacy agreements, and ultimately the acquisition of a waiver of consent from the Health Research Declaration Committee, we could then start linking clinical data within the Irish healthcare system. So what I'm going to show you now is some of the initial outputs of the data on some important aspects. So on the first slide here, we're looking at the burden of chronic kidney disease in both the Midwest and the Northwest health system. And you can see from 2005 to 2014, there's a steady increase in the prevalence of chronic kidney disease from about 6% up to 7.7%. And this represents about a 15% growth over that time point. Moreover, we can use that data to predict future growth in the prevalence of chronic kidney disease. And in our modelling strategy, we've predicted that the growth of CKD will increase to about 9.2%. And this is predominantly driven by growth in the elderly population. And that's why it's important that we have accurate data, reliable data, to predict growth in this chronic disease burden. And the next slide I'm going to show you is to look at the impact of chronic kidney disease on hospitalization. So what does it mean to have a diagnosis of chronic kidney disease? And in this slide, you see on the x-axis, there is the stages of chronic kidney disease from over 90% to less than 30%. So going from left to right, we can see that the rates of hospitalization increase such that individuals whose kidney function is less than 30% have about a 5-fold rise in the rate of hospitalisation. That's substantial, and that means we need to be targeting those patients with poor or very impaired kidney function. Similarly, for mortality, you see a similar picture. So compared to individuals whose kidney function is above 90%, to those whose kidney function is less than 30%, we see between a 10 to 20-fold rise in all-cause mortality. So to tackle this, really we need to focus on primary care to a greater extent. And that means we need to evaluate the extent of how we screen for early-stage kidney disease. And in this slide here, we're looking at the screening for early signs of kidney damage. That's leaking of albumin to the kidneys. And we can show that the screening rates were about 13% in 2005, and they've increased to about 38% in 2019, pre-pandemic. And we expect greater increases with the chronic disease management program. So I've shared with you the initial insights and experiences and learning from the National Kidney Disease Surveillance Program. It's up, it's operational, and we want to go national. And that's our plan, working with Claire and working with Fionnuala, who you'll hear about in the next few minutes. I suppose the key to all this is to understand chronic kidney disease, both the impact, the burden, and the effectiveness of treatment. We need to have good data, we need to have linked data, so we can develop a learning health system. Thank you for that.
Thanks very much, Austin and Claire. Fionnuala here from National Health Intelligence Unit. So I think Austin and Claire have very clearly demonstrated what you can do when you have the data, and then what you are limited in doing when you don't have the data. And that, registries are a great source of data. Our first speaker today showed us and mentioned multiple times where data from registries supported different aspects of their reform process. But traditional approaches to registries have been limited because of a heavy reliance on manual process around data collection and data validation, limiting resources available for the value add that registries can bring. But there's still a huge interest in evolving registries because of that value add. And Claire is working hard, and we're all working together to develop a registry solution for patients with diabetes, and working also with Austin to bring his renal surveillance system to a national footing. But there are challenges, and we're all probably aware of the challenges. They're up there on the screen, and I'll just mention a few of them. It's identifying the legal underpinnings, developing a strong governance infrastructure, looking at the technical issues, data collection, access to data, because we know data exists, but can we access it? Then if we're bringing together disparate data sets, the other variances in quality, coding, classifications, challenges with using structured versus unstructured data, then issues around data reassociation. We know we've loads of data, we've lots of data out there, but how do we bring it together? We have the IHI coming on board now as a patient identifier, and also the PPSN in play. And then scope of functions around registries. We want registries to have the greatest breadth of functions, and heretofore some registries have been constrained because of that resourcing to focus on a single function, and an overarching framework to address these challenges for registries. So looking at that point around the breadth of functions for registries, Claire alluded to her in her talk, and Austin has demonstrated it with his renal system. They should be directed across the 4 functions that are up on the slide there. So supporting patient care, both direct and indirect, supporting service metrics, activity trends, etc., providing information for service planning, and obviously a great source for research. So we looked within our grouping as to the legal basis for registries, and we identified 4 key pieces of legislation that would underpin registries. So we know the Health Act 2004, we're all familiar with it. It mandates the HSE to provide health services. GDPR then allows for processing of data, both personal and sensitive, without specific consent, if it is carried out in an official function of a data controller. We've looked at the use of the IHI in this scenario, and it meets with the primary and secondary purposes as defined in Health Identifiers Act 2014. Obviously, when we go to that 4th function about research, we're leaning on the health research regulations and the health information bill that Murish alluded to earlier, will provide clarity around that data sharing, use and reuse of data. We've looked then at a potential roadmap, a technical roadmap to bring us to where we want to be with our diabetes registry solution. So working through 4 phases, starting with a prototype to test out feasibility and test components, moving through then to a minimal viable product where we will have the minimal functionality and garner feedback, incorporating that feedback to move to the intermediate phase before finally reaching our mature solution, which is the North Star vision. We are leveraging expertise from across the HSE and also in academia that Claire referred to earlier on. And we have the data flow schema there, looking at the data sources that are available currently for patients around diabetes, with diabetes, bringing them together through reassociation, integration, deduplication and case finding to develop that patient cohort view around patients with diabetes in the first instance and to meet the 4 functions that we referred to earlier on. We've looked again towards governance because this is obviously looking at patient data for that group of patients with diabetes, so governance is key. There's been a lot of initiatives within HSE around data governance and management, including DAME, and we will align with them and with international and national best practice. We are looking to develop a 3-tiered or 3-layered structure around governance with strategic, tactical and operational layers. Data governance again is key. And clear definition of user roles and access based on user roles and stakeholder engagement as we move to develop our governance, including patient representation. So just final slide, and I'll move through this quickly. We do feel the time is opportune now to move forward in this space with the diabetes registry solution. A lot of things have come together. We have interest from academic partners. We have very huge engagement with clinical leadership, with colleagues in e-health, in integrated information services. We have the great advantage of learning from the work that Austin and colleagues have done down in Limerick with the National Kidney Disease Surveillance System. So we feel the time is right to evolve this further into finally to have that solution, that diabetes registry for patients in Ireland to meet those 4 functions. Thank you.